So it's my pleasure to introduce today's speaker, Dr. Ankit Sarin, Chief of the Division of Colorectal Surgery at UC Davis. He joins us today to discuss the role of AI in colorectal surgery, including current applications and its role in clinical practice, research, and surgical education. So thank you so much for being here, and I will hand it over to you.
Thank you so much for inviting me. This is mostly a primer. And okay, so I'm going to talk about artificial intelligence in surgery. It's a little bit broader than colorectal surgery because, unfortunately, the most of the applications and stuff aren't colorectal specific. That being said, the talk is focused on a bunch of applications that are relevant to our field as well. Before I get into that, I just wanted to discuss first my financial disclosures. I'm a consultant for Averto Medical, and I collaborate with a not surgical. You'll see one of their works on this slide, occasional proctor for Intuitive. So you guys are all aware of this, no matter where you are in the country. What you're seeing here represents every major hospital in America today, and this is about to get much worse. Pre-pandemic, hospital occupancy rates were about 65%, 64% to be accurate, and post-pandemic, they're about 75%. The expectation is that the national hospital occupancy rate is going to reach about 85% by 2032, and that's a big problem because once you start reaching that capacity, you start having bottlenecks all over the place. You try to order an MRI, that's going to take 3 weeks. You try to depend on the MRI for any further work, that's going to get delayed. So this is a big problem. And why is this a big problem? There are three factors that are driving this. One is our demographics. The second is our workforce. And the third is system inefficiencies. As far as the demographics are concerned, this is going to be the first time in the next 5 years where the US population above 65 is more than the number of children under 18 in the entire history of America. What that's going to mean is there's an increase in population above 75 years of 54.7%. And of course, as we are aware, elderly patients require a lot more surgical services. Seniors are 12% of the population, but account for 40% of hospital discharges and 48% of inpatient days. And so the anticipation is that by 2030, we are going to see a 14 to 47% increase in surgical demand. At the same time, 42% of physicians are over age 55, and a quarter of physicians are over age 65, surgeons specifically, which means that you're going to get an increasing demand with a decreased supply. In addition to all this, there's the administrative burden that we all feel, the access to delays, the turnover times, and all of the administrative bottlenecks like prior auth that we are all so accustomed to. So what's the solution? I can tell you confidently that there isn't one. There is no scope for adding more money to the system, and the amount of money that will be required to take care of that kind of population with this kind of workforce is just not going to happen. So what do we have going for us? Perhaps artificial intelligence may help, because while our capacity worsens linearly, at least so far, artificial improvement has improved exponentially. And that's been seen on the large language front, where medical question answers accuracy has been improving exponentially over the last 3 years. The amount of annual savings for the US healthcare system has been anticipated to be up to 5 to 10% of the total cost if AI is used effectively. And FDA-approved AI devices have increased at least sevenfold in the last 3 years. Why that's important is because if artificial intelligence saves each of us even 1 hour per day, that's the equivalent of adding thousands of surgeons to the workforce without training a single one. And that's why I feel strongly that we need to get involved and understand artificial intelligence and what it means. So today I'm going to try to give a little bit of a technical foundation for understanding artificial intelligence. talk about some tools in current clinical practice, and then some of the concerns which you guys, I'm sure, have heard about, but I'm going to try to ground that with some data and some specific literature. And then some emerging applications which are quite exciting for our field and surgeons in general. Understanding AI, first of all. So artificial intelligence is a very broad concept, basically machines performing anything that requires human intelligence. Um, Machine learning is a subset of this, and deep learning, which is where all the recent work has happened, is a subset of machine learning that uses multi-layered neural networks. The way neural networks work essentially is by using layers where um, data that goes through the layers and somehow learns a representation of what's being told and is able to classify that. So, for example, in this particular imaging visualization, this is a handwritten written 3 digits, and this particular neural network is being trained to recognize the three. And initially, it's very poor. It gives this utter trash result. But over time, if you teach it that there's a cost of the difference between the true answer and the false answer, it can, using something called back propagation, be taught to recognize a handwritten letter. And these patterns can be learned using either supervised learning, um, which is when surgeons or physicians annotate exactly what the answer is and teach the AI that through multiple loops, or unsupervised learning, where you're taught to recognize patterns in the data by just giving large volumes of data, or reinforcement learning, where you give the AI specific feedback on whether it's correct or not. The sea change and what's led to the recent sort of interest and explosion of AI has been through something called the transformer architecture, which came out in 2017 with a very famous paper called Attention is All You Need. And the intuition behind the transformer architecture and more generally attention in general is that by paying attention to a specific input and correlating that with every other word in the input, you can somehow ascertain what the context being asked is. So the typical sentence that's used, for example, is if you say the child did not cross the road because it was, and you say wide, it automatically implies that the street was wide. Or if you say because it was scared, it automatically implies that the child was scared. Or if you say the child did not cross the street because it was dark, it automatically you know specifies that the environment was dark. And the way the artificial intelligence model is able to understand what the context is and what the it means in that sentence is through this architecture of transformers using self-attention. Now, using that same architecture, what these large language models, OpenAI, Claude, etc., have done, have basically used attention at a planetary scale, training on massive internet-wide databases to learn complex patterns, relationships, and structure in human language. And that's essentially what has led to all of the recent advances in artificial intelligence. But one thing you have to understand when keeping this in mind is that just like a JPEG is a lossy compression of an image, the entire large language model is a blurry, lossy compression of the internet. And what that means is if you ask it a specific question and it cannot identify that specific answer, it tries to fill the gap by inventing details that were never in the data. And that's what we call hallucinations. So hallucinations are essentially a decompression artifact. And this becomes extremely important in healthcare and surgery and medicine in general, because if you just use these models de novo, they are going to hallucinate. That being said, what's really been working for current clinical practice are some of these tools that I'm going to sort of walk through. So the most common one that you will be quite familiar with, and these are all the different companies that are involved with this, are AI scribes. And they're essentially ambient listeners to the environment, and they try to capture the clinician patient conversation and then automatically generate documentation. For those of us who have used them, they tend to be pretty good. And there's data supporting this. I mean, Stanford found physicians noted at least a 96% ease of use, Kaiser permanently good satisfaction. Lots of places noted a time reduction, at least 1 hour a day saved per physician. My personal experience with the one that we use, which is A Bridges over here, is that they seem to be very good for uh, primary care conversation. So if you talk to a patient about a colectomy and you give all the risks, possibility of leak, possibility of infection, bleeding, etc., and then you also ask them about their blood pressure and whether they have diabetes or not. When you finally get the assessment and plan, it'll give it in blocks. And for the entire conversation on colectomy, it'll say, um, had a discussion on colectomy, risks and benefits discussed, and that's it. And then it'll give another block on diabetes discussed, no change in plan, hypertension discussed, no change in plan. So it doesn't get granular enough that's required for our specialties. But that being said, these continuously improve. And unlike humans, when the models improve, they improve for everyone. So they're here to stay. Knowledge retrieval. One of the best ones for knowledge retrievals is open evidence. Some of you may have used it. It's done really well on the USMLE exams for those who care. But more importantly, all of the questions that it answers tend to be returned with citations that have been vetted, with content that has been run through essentially some verifiers to make sure that it comes from sources like PubMed or Cochrane. And so therefore it's grounded in fact. And this is the one to use if you're looking up some information rather than using ChatGPT or Claude or Gemini directly. Specific to colorectal, some of the work that has been done in computer vision and radiology is this particular one that looks at MRIs. And what it tries to do, for example, is segment out rectal tumors. So normally it takes a radiologist per case about 38 minutes to accurately segment out exactly what the radiologist thinks is the rectal tumor across MRI images. This particular model, now of course several years old, was able to identify these specific tumors, as you can see, case 1, 2, 3, and 4, in about 2 minutes. So definitely saving a lot of time. But at that time, it wasn't very good. As you can see in case 5 and case 6, it wrongly identified the base of the penis essentially as rectal tumor rather than the tumor itself. So these models will continue to get better, and this one is, of course, many years old now. But I definitely see a role for MRI segmentation, and I think this is going to become increasingly important as we move towards watch and wait and using much more nuanced decisions around whether we choose to operate on those patients or continue to watch them. Pad Chat is another one. It's out of the lab now. But what's really nice about it is that you can place a slide with tissue and then ask it questions. And it just like a chat stream, it can tell you what you're looking at, what the pathology is, what the concerns are. It has a pretty good, almost 90% accuracy, as long as it has the context for what it's looking for. If it doesn't have the context, the image only accuracy is 10 percentile lower. And it's been tested on at least more than 100 diagnostic questions and can cover a lot of different diagnoses. So I think this again, because it's pattern recognition, just like radiology, is going to come and become much more important going forward. For colorectal specifically, the one that has reached most clinicians is computer-aided detection systems for colonoscopy. And currently, almost every endoscopy company, Pentax, Medtronic, or Olympus, all have some versions of this. And the idea behind this is that these, as you're going through the colon, this places bounding boxes, those green boxes that you see where it thinks there's a polyp over there. And it's been shown to increase adenoma detection rates across, prospective randomized trials by 13%. And especially in polyps less than 5 mm, which experienced endoscopists tend to miss, it's been shown to have a 29% improvement, which is pretty significant. One of the big concerns with the AI assisted polyp detection, though, which I don't think we yet have an answer for, is the whole concept of deskilling. Because it's been shown that if you start using these routinely, over time, you tend to miss more polyps than you would have otherwise missed before you started using the system. And I don't think we have a perfect answer for how to deploy these systems if we are going to get so accustomed to them that we start depending on them completely for patient care. There's a lot of work been done on perioperative risk assessment, and some of these use NISQIP data to show that the complication rates, and they are actually much more predictive than NISQIP has been. Um, More currently, studies like Alba et al. Have started looking directly at the preoperative notes and finding specific postoperative risks like wound infections and anastomotic leaks, and they have a significantly higher accuracy than any traditional scoring system, including the American College of Surgeons system. And the more you integrate into the model, including the preoperative notes, the comorbidities, and the lab values, the more you're able to create a personalized risk profile and therefore allow for targeted preoperative optimization strategies. Um, in For every 100 patients who were looked at this, the systems were able to identify 36% additional patients who would have been missed if they were just using traditional word embeddings to identify risks. So they're starting to become pretty powerful. And in the post-operative recovery phase too, we are seeing a lot of sensors being used, uh, continuously sensing movement, sleep, and temperature, as well as heart rate and heart rate variability to determine if the patient is developing a leak. Um, the work that's going to need to go into this, and this is where surgeons become important, is validating these tools and understanding whether they are reliable across organizations and across populations, because that work hasn't been done. And until that work is done, these are going to remain in the realm of experiment or research. In the computer vision space, there have been some work, mostly in urology and specifically prostatectomies, looking at videos and using those to um, write operative notes. And they've actually been found to be in some ways more accurate than surgeons in documentation of things like lysis of adhesions, blood loss, etc. And I think this is going to come as well, along with, of course, recognition of skills in training, which I've left out of this talk, which is a whole other topic, but it's a whole big part of computer vision. And then there are a whole host of them that are out there that I'm not going to go into, such as optimization of the OR schedules, optimization of staffing. All of these are being deployed across hospitals and hospital systems at great scale. And not only will we anticipate that they will learn from those systems, but also help improve efficiency. Of course, All of this comes with a number of caveats, which I'll talk about. One of the things that's often brought up is, well, you can talk about artificial intelligence all you want, but artificial intelligence is not holding the patient's hand when you're talking to them about cancer and prognosis. And this is true. But that being said, every single study that has looked specifically at empathy has found that AI models, large language models, tend to be more empathetic than physicians. And that's a sorry state of affairs to some extent, but it's also because what we fail to recognize often as a physician community is that from a patient's perspective, we physicians ourselves are black boxes. We take in information that they give us. We then analyze that information within our own minds, and we give them recommendations on what we think we should do next. And while we are analyzing that information, we sometimes fail to spend enough time on the empathy piece of it. And that's where these models actually tend to have a much higher empathetic response because they've been trained on human language. In one JAMA study from 2 years ago, they had a 9.8 times higher empathetic response compared to physicians. And even for cancer, they were rated consistently much more empathetic than humans are. So the fact that if we think that empathy is what's going to make us differentiated from these models, unfortunately, that's not the case. The one place perhaps we still are ahead of artificial intelligence models is in explainability. So, like I mentioned, the patients see us as black boxes, and artificial intelligence, large language models certainly are black boxes. But there is now techniques being developed like SHAP and LIME that allow us to understand why models are giving particular recommendations. And I think this is going to become more important. I know there's been regulation in Europe to make sure that any artificial intelligence models that are going to be patient facing are required to give some reasoning behind their recommendations. And I think this is going to happen going forward much more. But explainability is a big field of research and interest, and I think this will get better over time. The other big concern raised with artificial intelligence is privacy. And it's true. If you start sharing patient information, it tends to make the models better, but it's not okay to share information. So how do we get around that? And currently, the best method around this is something called federated learning. And the idea behind that is that within each unique health center, the models learn on specific patients using PHI, but they don't use that, they use that PHI just to update the model weights and the numbers that go into the models without actually retaining any of the patient data. These numbers and vectors are then cross-correlated across organizations and healthcare centers to create a global model that should be better than any one of them at any individual center. And because the models are not sharing PHI, but they're only sharing weights, you can imagine that you get past the concern about PHI while still allowing the models to learn from different centers and different patient models. And that's the federated learning model. And it's been developed for breast cancer, prostate cancer, stroke diagnosis, a lot of work being done specifically in the UK National Health Service, where the systems are a lot more cohesive. As I mentioned, hallucinations is a big piece of it, and hallucinations are decompression artifacts. They have gotten much better now. And the reason they've gotten better is that when these models first came out, the reliance was purely on semantic learning, which was the model's weights to give the answer. Now, none of the frontier models use semantic learning alone to give answers. They use specific tools. So if you were to ask a model, when is Halloween this year? Instead of looking at its own weights, where I'm sure Halloween has been mentioned a million times, and different dates have been given. The models now use a tool to find what the holidays are in the US for this year and find the date for Halloween and return that as a specific answer based on a specific tool. Similarly, if you ask it the weather in a particular place, instead of guessing what the weather would be based on all of the language that it's learned, it actually uses a tool, specifically a weather API, to find the local weather for the question that you've asked and gives you an answer. So that's why these hallucination rates have come down significantly. And the latest models, even this number of 0.25 to 0.5% is probably high compared to 2026. Bias is a big problem, and that's something that we can all do something about because the data that goes in is what gives the answers out. And there was a very important study by Obermeyer and all that showed that at the same risk score, Black patients carry 26% more chronic conditions. And the problem with this particular model and why it said this for the same risk, even though the patients were a lot sick, Black patients were a lot sicker, was because the model was designed to look at what the cost was of care. And if you can imagine, Black patients were getting less cost of care or were having less money spent on their care, even though they were sicker. And therefore, the numbers seem to suggest that at the same cost, um, they were the same, but Black patients were carrying 26% more chronic conditions. So I think it's important as we, as physicians and clinicians and surgeons, validate these models, we are very thoughtful about the data that goes into these models, and the data is verified against real world scenarios to ensure that there's no bias in it. And my personal pet peeve is AI slop. And that's, we all face this all the time now because these AI chatbots have become so ubiquitous. You get, longer emails that say nothing new. You get slide decks filled with charts, but there's no judgment. You get summaries without any decisions. And everything feels very busy, but nothing actually moves forward. No decisions are taken. It all looks very productive but creates no real value. And I think that's the big harm of all of the day-to-day AI contents that's out there. I think we have to fight against that and use these artificial intelligence tools wisely. I'm going to talk now about some really nice emerging applications, some of which I have the opportunity to be involved in. This is one of my favorites. So this is a system developed in Japan by some surgical oncologists who do a lot of colon cancer work as well. And they've created this platform out of the work that they did. But just so you recognize the amount of work that goes into it, this particular surgeon that I work with now, Kobayashi, they spent a lot of time going over specific frames of operative videos and highlighting individual nerves, individual tissues for the model to recognize them so that when the model sees operative videos in real time, it can point these out. And here you can see what the model looks like. So in light blue is the fibroareolar tissue that the model is recognizing in real time and allowing the surgeon to see. In green, lime green, are the nerves that you can see, the hypogastric nerves. And at each time frame, it's recognizing these nerves and showing them in real time. Right now, the system, of course, is for education and research only. They're going to try to validate it specifically for the US population because obviously, our anatomy is quite different from Japanese patients. But this, for example, is the ureter. And this ureter doesn't have any stent in it. It doesn't have any ICG in it. It's purely on the basis of recognizing the tissue. Again, This particular model can be used in both robotic and laparoscopic, any video feed really, presumably even open. And so here you can see on laparoscopy, it's showing the connective tissue and the nerves as the surgeon is operating. And here he's also highlighted the pancreas. So he's done it for um, nerves, connective tissue, ureter, pancreas, duodenum. Um, and I think this is going to become important because, as you know, we as colorectal surgeons work in embryological planes, and so we don't have the luxury of having the exact preoperative um, um, CT scan or MRI look the same when we are working intraoperatively. These planes have to be separated and shown in real time. And so a model like this that is able to recognize tissue and important structures like nerves and ureter is going to be key, I think, in avoiding injury going forward. Sorry. There are other emerging technologies coming out. This particular system called the Blair system was developed on prostatectomies. But the idea behind this system is to recognize upcoming bleeding by watching lots and lots of videos. And the way it's trained is in some is like this. So you can see on the top of the screen, on the left-hand side, there's a monitor, and it's giving at this time a 95% chance that you're going to have bleeding in the next 3 seconds. And if bleeding occurs, which it did in this case, it's labeled a true positive. In the second case, it thought there was going to be bleeding, but no bleeding really occurred. And so that's a false positive. And then, of course, the ones that we are wary of, where it did not think there would be bleeding, or the chance of bleeding was only 32%, and then you did have bleeding, which is a false negative. So they're training this model, and it's been shown to have an accuracy about 70%. With an expert inter-rater reliability of about 79%. So it's good, but it's still experimental. But I think these systems are going in the direction of allowing us to give intraoperative, real-time predictive analytics. The other one, which is not colorectal based, but is the absolute frontier of computer vision, is the system from John Hopkins and specifically Axel Krieger's team and lab, where they have been training a robotic transformer to do cholecystectomies. Initially, they taught it things like this, which is knot tying. This is a completely autonomous knot tying. There is no human in the loop here moving this robot. And when a researcher puts a screwdriver in, it was still able to recognize and work around it. This is on actual tissue, and you can see it's trying to create a knot autonomously. And then this one is an actual on a porcine model doing a cholecystectomy. It's been sped up to about 8 times of normal, but this is again completely autonomous. A medical student actually did, I think, 80 of these procedures for it to train on. And then completely autonomously, it's taking the um, cystic duct and the cystic artery. And what's cool about the way they did this is they combined a large language model on the top, which tells it what to do, and then the model follows the wordings of the large language model to do what it needs to do for a cholecystectomy. And so combining a computer vision model with autonomous surgery along with the large language model led to a breakthrough like this. So a lot of people ask whether you expect autonomous surgery to be coming, and what I would say is this is the absolute frontier of the field, and this is for cholecystectomies in porcine models on a very very specific ask. So I think we all have our jobs for a number of years. I don't think we should get too worried about it, but it is pretty cool to see this coming. leading towards the end of the talk, I would say that surgeons need to get involved in artificial intelligence. They need to understand the basics, pilot the tools, definitely validate the outcomes so that it's us who are driving the fields. And while doing so, understand the limitations. We really do need to lead adoption because this is going to come, and this is something that we either will be a part of or it'll be us being driven through it. I'll give you my own personal, very simple example. So I wanted to do a robotic TAMIS procedure, which a lot of you might now be familiar with. And when I sent one of my patients to get this done, the reviewer from the insurance company sent me this return saying that robotic TAMIS is considered experimental. And I was really upset by this. And I was mostly upset because the paper that this reviewer quoted was a paper that I had written on robotic transanal excision of rectal lesions. And so I was quite annoyed. And I asked one of my models to create a draft response. I gave it specific articles that I wanted it to quote, and I asked it to search for more. And it created a very nice response with a clinical background and rationale. It named and gave specific links to all of those articles. And this was literally 36 hours before the case. And then, of course, I was allowed to do the case. So you got to, fight for what's right. And the AI models can sometimes help you do that. And so this is a simple way to use these models in current clinical practice. Of course, when I, use the models, you've got to be careful. So there was no PHI when I was asking the model to search for information, etc. But I think that this is telling on how it can be used effectively. And on a personal note, I have two daughters over there, and I've asked the models to help me create nice math questions for them whenever I'm bored and stuck with them and they're bored. Um, and it writes amazing, very specific math problems that I can then give them to do. I did have a couple of slides on looking forward, but I've realized that the timeline of these things is accelerating beyond any projection. So no matter what I say over here, it's not going to really be valid in a year or two. So I'm not going to make any predictions. These are all the references that I've used in this slide. And thank you. I'm happy to take any questions that you might have. I'll stop sharing now.
Thank you. That was awesome. So a couple questions. I know you just said that you're not gonna make any guesstimates on timelines, but the critical structure identification, I feel like we hear more and more about that. Is that something that we would expect to be using in the next couple of years? And is that more for things like a routine cholecystectomy, or are we going to be seeing that with more kind of like complex redo pelvic operations, things like that?
Yeah, it's a good question. I mean, I think that if you think about like operative vision, computer vision, which is the question, the answer, the broad field is divided into two categories. One of them is the whole work that's going into the patient-facing arena, which is things like identification of ureters and bleeding, etc. And that's increasingly been combined with additional sensors on robots, with ICG and other smaller molecules. And I see that coming. And I think that that stuff is really going to take off in the next few years because I think we all see value in it. And like you said, I think that we would currently like to see that in complex cases where it's becoming difficult to identify nerves, etc. But like any of these technologies, once you start using it in complex cases, you realize the value even in simpler things and you start becoming accustomed and used to them. So I think that'll happen. The challenge, of course, is that in surgery, the biggest bottleneck right now for computer vision is that we don't have the kind of data sets that you get in language. If you think of autonomous cars, for example, there's millions of hours of data. Right? Take Tesla as an example of people driving cars and sensors and roads and all of the things that can happen. In surgery, that's just not the case. We don't have large data sets. The largest well validated data set that's out there is cholecystectomy 80, which is 80 cholecystectomies individually annotated by surgeons for all the steps and movements and everything. In the case of colorectal surgery, the best data set that's out there is something called the Dresden Surgical Anatomy data set. And that essentially is an annotated data set on anatomy, and it is annotating individual organs. So not even the steps of an organ. The only work that's really been done in this space is from Japan, and that's where this ANOT model has come from. So I think that the biggest bottleneck is the fact that we don't have great data sets. It's a lot of work for surgeons to annotate steps, and to be able to recognize individual structures and feed that into a model. So I think that's what's taking time, but I absolutely see these things coming in the next few years, through a lot of different pathways that are being developed both by large companies like NVIDIA and by individual labs, like Philippos, for example, where you're going next year. So it's coming. The second big piece of computer vision tends to be around teaching, training, education, and skills, right? And also evaluation of surgeons. And I think that's a much more tricky piece from a regulatory standpoint because, on the one hand, a model being able to predict whether a surgeon is efficient or not efficient or is likely to have a complication or not is a great tool for teaching and learning and improving, just like M&Ms are. But the big concern is how is this going to be handled on the liability front? And which surgeon will want to share their data and their videos and stuff if they're not protected when it comes to liability? And it doesn't have to be a liability from a legal standpoint. It could just be liability in terms of privileging or getting more cases or even marketing and patients going to surgeons who some AI companies decided is a much better surgeon than others. So I think that's a much more tricky piece of it. But to your point, I think these things are going to come in the next few years.
Interesting. I feel like with the like structure identification, it could be really useful, especially for early residents, like ones and twos. But then I feel like as people become more accustomed to identifying those structures, they would almost become dependent, like how you were talking about the de-skilling. How do you think that that affects surgical education? Because I almost feel like it goes both ways, where it helps and then it later hurts.
Yeah, I mean, it's a challenge. I mean, and it's a challenge in not just here, but in so many places, right? Like when I was training, laparoscopy was becoming big and we all became really facile at laparoscopy. And then I had to learn robotics more as an attending than as a resident. But now I see the residents are much more facile with the robot, whereas they are completely de-skilled as far as laparoscopy is concerned. So I think it's the same idea as we get dependent on more structures that are more reliable, products that tell us what's going on with more validity and with more reliability, we tend to become dependent on them. I think that's going to be a challenge in the literature that you look at for polyp detection. It's the experienced endoscopist who start missing polyps once they've been exposed to these tools. And so for novices, it's an even bigger challenge. I think we've got to find ways to, um, you know, solve the problem. I'll give you an example. So I've been working on an AI educational tutor for med students for their surgical shelf exams. And the idea is that, it gives you questions and you give it answers and stuff like that. But the the idea behind setting up the tutor was such that instead of, if you ask it for a hint, instead of giving you answer or closer to the answer, what it does is it takes the question and it breaks it down further into smaller questions. So it forces you to think. And so the whole idea was to avoid this whole problem of de-skilling, right? But the challenge is that, we did a validation study for med students, still not published yet, but Half of the med students really liked it because they felt that it challenged them to think. But half of the med students were like really annoyed with it because they were like, I just want the answer at some point. So it's a global challenge. Yeah.
Interesting. Um, I guess the other thing with the structure identification, I imagine that people aren't going to trust it fully until it is absolutely perfect. Like it seems like even if we are not absolutely perfect, if we're going to rely on this type of technology, we would expect that it is perfect. So I guess when do we make that call? Like how do we know if it's going to be right every time?
Yeah, it's tricky. And if you can imagine, from an FDA or regulatory standpoint, it's very, very tricky, right? How do you decide what is the right number or amount? How much risk are you willing to accept? How is one ureter injury enough? Is one nerve injury enough over a million cases? Like, what is the cutoff? It's very difficult to say. I think that's going to be a regulatory challenge. The way I see this happening is, like most things, this is going to first start out as an educational tool, primarily just to show residents where the nerves are, where the ureter is, without any regulatory burden, without any onus on the technology to make any judgment calls on whether you should cut at a particular place or not. I think then the next level is going to start giving caution about what may be something there, and you should exercise judgment. Just like with the endoscopy right now, it gives bounding boxes, but the endoscopist still has the initiative of deciding whether that's a polyp or not. And there might be a future state where it actually blocks you from hurting something if your bovie is getting too close to a critical structure. But I see that much further down the line, closer to autonomous surgery, not very soon. And the biggest question is risk and the regulatory burden and who carries that burden. Yeah.
So I guess early on, it's going to be less about the technology telling you what to do and more about it telling you what not to do.
Yes, absolutely. I think that that's going to be for sure. And even when it tells you not to do, I think initially it'll be just saying exercise caution rather than specifically telling you this is the ureter. It'll be saying something like it thinks the ureter is here. One of the big issues, having talked to the Japanese surgeons, is that the AI technology is based on the operative feed, right? And so it only looks at the pixels on the screen. It can only look at a two-dimensional view and tells you where the ureter is. Unlike a stent or ICG, which is around the whole structure, it can only look at it in one dimension. So it's a surface level visualization of the ureter. And that may or may not completely correlate when you think about it from a three-dimensional standpoint, especially if you mobilize the ureter in a different direction as part of some cancer operation or just from being in the wrong plane.
Got it. And then you were talking about how AI produces more empathetic communication. Um, like from the patient perception of that, how do people care that they're not talking to a human? Like, I would have to imagine that it's nice for them to be looking at their living, breathing doctor and get information from them.
Yeah, I mean, you would think, right? But the truth is that, I have family members who will routinely ask ChatGPT or other AI models for questions even before they go to the doctor. And and in some cases, it's valuable because they learn what specific questions to go and ask the doctor. And in some cases, it's valuable because they get answers much before they reach the doctor. But of course, it comes with its own hazards, right? If you don't ask the right question, the model is giving you answers based on generic, information that may be completely irrelevant to you, and they don't know what the relevant context is for their specific case, right? So
Hmm.
it's a problem. But universally, these models tend to explain things with empathy. So we are not in the habit, like if a patient comes to you and says, I have colon cancer, we are typically not in the habit of saying, I'm so sorry to hear that you found out you have colon cancer. How's your family handling this? Are you doing okay from a financial standpoint? We don't ask these. We are not trained to ask
Hmm.
these. We've learned to push this down. And these models typically lead with empathy. And so, for the most part, even if they're not a human, most patients do find them to be, anthropomorphic for what you have it. Yeah.
Got it. Interesting. And then video for the operative reports. When does that become like a legal issue? Like the way that things are documented or what recordings actually look like. Do they even keep recordings? I don't really fully understand how that works.
Yeah, it's a regulatory minefield. I mean, the way most places are deploying it now is you deploy these models locally, and so first of all, as far as the operative report is concerned, I mean, you can imagine an operative video that's fed into a model, creates a document, and then the operative video is destroyed immediately, and so there's no liability risk. Just like if you were to do a live feed at the time that you did the operation and send it to a model, but then after the operation, you haven't recorded anything. So you can stay out of it. If the model is local and it's stored locally within a safeguards, then there's no PHI going back to the company or anything like that, right? And
Hmm.
then the question of, what the liabilities of a company, whether they are accurately catching that information, I think that is more solvable because if you think about it right now, like we often have residents who might write our operative report, or we might have, we might use a structured operative report, etc. But at the end of the day, the surgeon who signs off on that operative report is legally obligated to read that report and make sure it's accurate, and the
Hmm.
work describes what was accurately done. And so I think it's going to be similar with these models that are using computer vision to document the operative report. For health system standpoint, I think the value driver is the fact that these models may capture stuff that you might not have captured otherwise. Like you do a procedure where you also did a sigmoidoscopy but didn't think of anything of it, and then the model might say, well, you did an LAR, but you also did a sigmoidoscopy and something like that.
Hmm.
So I think that they might be able to provide value in that manner. Yeah.
Sure. Okay. Interesting. All right. I think that's all the questions we have. Yeah. But yeah, that was awesome. Thank you so much for being here and for sharing all that.
Yeah, no, thank you for inviting me. It's a brave new world, and I encourage all of you to please get involved and remain updated on this. It's moving very fast, and I think if just like so many things in our lives, if we don't participate in this, it's going to lead us in paths that we don't want to go down, perhaps for our patients.
Oh, awesome. All right. Take care. Thanks again.
Thank you so much.